Good morning. The topic assigned to me is cell-based regeneration strategies in lumbar disc and its limitations. Well, I'll give my introduction. I am Professor Dr. Manish Khanna, former head of orthopedics and in charge orthobiologics in Autonomous State Medical College, Ayodhya. But now I am working in Lucknow as a Dean Academics to Mayo Institute of Medical Science, which is now called as Dr. K.N.S. Mims Barabanki. I am chairman to Indian Stem Cell Study Group Association and chair to Educational Day World Orthopedic Association, SICOT. So without wasting time, I welcome you all on behalf of Indian Stem Cell Study Group Association and Indian Stem Cell Study Group, a orthopedic regenerative group, which is devoted to fellowship program in orthobiologics for orthopedic surgeons. So I think in last 1 hour, we are agreeing to the point that future of the medicine surgery is regeneration. So definitely yes, coming to this disc regeneration, after just saying this line, that spinal cord regeneration is still in a research form for all of us by using mesenchymal stem cell or bone marrow cocktail. Now, the terminology has to be very much clear. What is stem cell? So stem cell, characteristically, when we are saying mesenchymal stem cell, then it is to be said as stem cells. Otherwise, what we are using is PRP or bone marrow concentrate, a bone marrow cocktail, which is a mixed population of heterogeneous cells. Degenerative spine disease is really a problematic situation for all of us. And if you see across the globe, you can see this pink area. I mean, it's in the USA, it is a debilitating condition. I mean, it's a situation which is very troublesome. In coming decades, it will be worsened. And as all our surgeons here, spine surgeons here, so need not to tell much about the nucleus pulposus or the annulus fibrosus, but the most important thing is to remember is it's not always when the nucleus pulposus coming out of the disc, that is a herniated disc, the symptom comes. Sometimes the symptoms are even there when the degeneration is on. Radiological appearance of the disc degeneration is definitely shrinkage and the losing of the height, but in MRI, the things may be picked up a little early also. So whenever you are placing a BMAC or a PRP or MSC, whatever in the disc area, under the fluoroscopic guidance, the results will come. Pain relief will be there first, which is again subjective finding, but what we require is a evidence-based medicine. And that we'll try to work up in this coming 6 to 7 minutes. Now, similarly, whenever we inject MSCs, maybe autologous or allogenic, the idea is to restore the cell structure and the hydration, the nucleus pulposus cell structure and the hydration. So while we inject it, it reconstructs the nucleus pulposus matrix, that's very good, and it promotes the tissue regeneration, thereby reducing the nociceptive disc pain. That's why the patient have a pain relief, probably slowing down the catabolic process. Finally, rebuilding of nucleus pulposus. So this is the hypothesis on which we try to work. Now, we all know that the MSCs secrete the anti-inflammatory molecule, the platelets secrete, and that is why the inflammation is reduced whenever we inject some material in the disc. These growth factors, which are produced by platelet or MSC, they may restore the integrity of the extracellular matrix, which is very important in a degenerating intervertebral disc. So ultimately, whenever you're placing a stem cell, when you're placing a growth factor in the form of PRP, ultimately the apoptosis of the nucleus pulposus cells should be decreased. Proliferation of the cells should increase. Some catabolic activity should come down because of the decrease in inflammatory cytokines. And this is how a disc can be regenerated or can be prevented from degeneration. And as I've already mentioned, to assess the regeneration of the disc, what we require is a good elevated T2 signals in MRI, which is a proof of little bit of good improved hydration, restoration of the extracellular matrix. But whenever the studies are being done since decades, this is being reflected? No, it's not always been reflected. As far as the PRP has been considered, so it has been used in the discogenic log pain in a lot of the studies since 2011. I've just placed here a study from a Asian Spine Journal in 2017, where the intradiscal injection of autologous platelet plasma was being given. And this was a preliminary clinical trial. The results were enthusiastic. So this was data which was taken from only 14 patients. Average follow-up was of 10 months. So in all these studies, which we'll be discussing, sometime 10 months, sometime 8 months like that. The best part was the VAS score significantly decreased and it persisted to that extent for next 10 months. So that was a good thing. Now, this is a very busy chart, which is showing a comprehensive review of PRP in low backache. So now, 2016, 2017, 2016 by Tuikliu, this study, which is a randomized controlled trial. So in some studies, again, as explained earlier, a period of 6 months was being taken, sometime period of 3 months was being taken, sometime even for 90 months was being taken. In all these cases, 1.5 to 2 ml of PRP was being injected. And as mentioned, the pain was significantly being reduced. And but the question is whether these randomized placebo-controlled trials were able to provide a disc regeneration radiologically. So it was again a gray area to be commented right now. Then some clinical trials are still being on, some are being completed, some of the cases are being recruiting. So the first one is still being in the recruiting stage at Utah from United States, at the same time in California, where the platelet-rich plasma and bone marrow aspirate were being used in this data. Again, 1.2 ml of PRP plus 1.2 ml of bone marrow cocktail. 60 patients are still in the recruiting stage. 2 trials are being completed where the intradiscal injection of platelet plasma for discogenic pain was being given. One was a multicentric randomized controlled trial. So we are waiting for enthusiastically for the results to be out, but the preliminary data which is being available to us show a significant pain reduction. Sometime some hope in radiological parameters for increasing in disc structure, integrity. But if you say a wonderful disc increase in the space, it still is a dicey situation. So these results are promising. Further studies are needed to define the subset of the particular of the patients which are to be taken, which are to be subjected for intradiscal treatment. The problem is there is no standardization of using a PRP. The variability in the PRP preparation, the amount, there are so many things which are required for establishing any particular proof. Now, this was a study which was a review article done by Indian Stem Cell Study Group a few years back, in which we did a review article about the intradiscal use of platelet plasma, whether it is having any beneficial role in the management of lumbar disc diseases. So what we found was lack of conclusive evidences while using a PRP. There may be some beneficial effect in controlling the pain, which will be better than using a dipomedrol, truly speaking. But the structural improvement, we were not able to find any structural improvement. Then another use of PRP, a review article was being published when spinal fusion, when the spinal fusion is being done, sometimes the platelet plasma has been used. So this was a systemic overview of the meta-analysis. And what we concluded is the effectiveness of the PRP as a biological agent in augmenting spinal fusion is limited. Current evidence does not suppose the use of PRP as a adjuvant for a spinal fusion. So if you do it, if you don't do it, not much difference. Now, coming to the second part after PRP, that is the mesenchymal stem cells. Mesenchymal stem cells, lot of studies were being done in small animal models, but in larger vertebrate, they have a mixed response. We'll discuss it in coming few minutes of time. But before that, how MSC works. So MSC works with having anti-inflammatory effect, having a cytoprotective effect. Now, cytoprotective effect for disc is a protection to the nucleus pulposus cells, right? Prevention of apoptosis of these nucleus pulposus cells if they inject it. So that's better part, truly speaking. Stimulation of angiogenesis, stimulation of the resident progenitor cells there, and reduction of the fibrosis. To remember for intervertebral discs is that it is having 66 to 86% of water, and rest of the portion is by the collagen and proteoglycan, which is the main, bricks of the disc. Now, the nucleus pulposus, if you see, has a fibrocartilage lamellae, and this lamellae is actually made up of chondrocytes-like cells, which are actually chondrocytes-like cells, and they have been originated from the cartilage end plates here. From here, they originated, they come here. Sorry. Now, chondrocytes, whatever chondrocyte we are saying, or chondrocyte-like cell, what we are saying, they actually synthesize the proteoglycan. So that is why the health of these cells is very important. In few clinical trials, MSCs were being injected in the coccygeal disc of the rats using 15% of hyaluron gel as a carrier. And what significantly found was an increase in disc height in the rats, which is because of the increase in the matrix synthesis. And these results indicated that MSCs can maintain viability and can proliferate within the intervertebral disc of the rat. But if you compare this with the human studies, the results are not so positive to be given in an evidence-based form. So how it works probably, so whenever we inject MSCs, which may be from bone marrow or which may be from adipose tissue, they are able to differentiate into cellular phenotype cells of nucleus pulposus, right? And these cells which are being produced, they have a paracrine effect on the native nucleus pulposus cells through the growth factor. So MSCs, they may differentiate into nucleus pulposus phenotype, and ultimately what is required is a proteoglycan synthesis, which will maintain the health of the disc along with the maintaining the water content, which is a different issue. Now, further, it was been seen that these differentiated cells synthesize type 2 collagen, as I already mentioned, along with the proteoglycan, and so the disc height was being maintained. So I'm not going into much detail as out of the time right now. Just want to say that human trials, which was being done in the MSCs starting from 2010, moving down to 2020, they have a mixed response. Of course, the pain relief was been there, truly speaking, but actually, if you say radiological improvement, so initially in few cases, radiological improvement was been there as a disc height was been there, but a consistent radiological improvement in disc height was not being seen. And not going into much detail about the publication part, but yes, we'll again say that one of the paper again said that there's no evidence to support it in a constant regular human use. Now, this is a very important slide, a quick review why this happened. See, the animal discs, the rats and all the animals, they have more 20 to 30% of nuclear pulposus cell than human beings, human discs. Whenever we inject a stem cell in a disc, actually a favorable environment is not been always there because the host disc is acidic in nature and having an inherent lack of blood supply. So that's a challenging situation. And it was being published in University of Southern California. These all data has been taken from University of Southern California. They say that it will take a long time, decades for a disc to restore its 25% of structure by putting MSCs. So in conclusion, we can say the MSC therapy show promise for the treatment of IVD degeneration, but what we require is additional research, the clinical trials to be done to establish it. There are some open questions which I'm placing in hand, like What additional clinical evidence are required to establish the efficacy of stem cell therapy in disc? What method ensure accurate stem cell delivery? Because that's again a challenge. And we still do not know what is the long-term survival of the disc stem cells were placed in the disc. Thank you so much for very patient hearing. And I'll say that cellular therapy or MSC probably may be highly useful for the patient presenting at a correct disease at a correct time. But the time will tell. Thank you so much for a patient hearing. Thanks a lot.